Good morning or afternoon, everyone, depending on where you are. We are so excited that you are all joining us today for our latest Fireside chat at the National Hypertension Control Roundtable. My name is Jenny Bogard, and I am the Executive Director. And happy Heart Month! I know we only have a few days left, but I'm wearing my red to celebrate Heart Month. I hope everybody had a wonderful month thus far. So, today's conversation, we will hear from experts and a panel to talk about busting myths to single pill combination therapy, and you'll learn about everything you need to know. In today's fireside chat, over the next hour, we will hear some new guidelines, we'll hear some panelists' individual remarks, and we'll even dive into some case studies, followed by a panel discussion. We will, of course, have time for some Q&A from all of you, so if you have a question for our experts, please feel free to type it into the Q&A icon at the bottom of your Zoom screen. If you don't see it, you can also type it in the chat box and we will make sure to address it. If we can't get to every question, we'll try to follow up afterwards. So without further ado, I want to welcome my colleague and friend, Hilary Wall, who is the senior scientist and the Million Hearts Science Lead at the Division for Heart Disease and Stroke Prevention at the Centers for Disease Control and Prevention. Hilary, the floor is yours.
Great. Thanks so much, Jenny. And I am just thrilled to be here today with our very esteemed panel to bust some myths related to single pill combination antihypertensive medications, or SPCs, which are also referred to as fixed dose combination medications, or FDCs. And I see SPCs as sort of a secret weapon for hypertension management. Not only do they deliver the evidence-based antihypertensive medications, which are critical to blood pressure control for so many patients with hypertension, but they do it in a way that supports medication adherence. And we know, I'm in this group too, that people are more likely to take one pill than they are two or three. So SPCs are medications that come with a built-in medication adherence strategy. And the real question is, why aren't they being prescribed more? And that's really what we're here to discuss today. And we hope that you walk away feeling empowered to prescribe them more. So as you likely know, in August of last year, the American College of Cardiology, the American Heart Association, and multiple clinical societies published a new guideline for the prevention, detection, evaluation, and management of high blood pressure in adults. The new guideline states that in general, initial combination therapy with two drugs is reasonable in non-frail adults with stage 2 hypertension, blood pressure greater than 140/90, and those with stage 1 hypertension, blood pressure greater than 130/80, who are at high risk for cardiovascular disease. And this latter group includes patients with a 10-year prevent CVD risk of greater than or equal to 7.5%, or patients with diabetes, chronic kidney disease, or clinical cardiovascular disease, which includes coronary heart disease, stroke, and heart failure. Because most patients with hypertension require two or more antihypertensive medications to control their blood pressure, starting treatment with single pill combinations rather than equivalent free pill combinations is preferred, because, as I said earlier, it improves adherence. Now, previous guidelines had certainly included SPCs as a treatment option for hypertension, but it was more of a, yes, you can use them if you want. But this new guideline really emphasizes that SPCs are the ideal way to initiate treatment for many patients. Now, joining me to talk more about SPCs is a truly fantastic panel of experts. I'm gonna introduce them all now, and then they each have, we've given them a few minutes for some opening remarks on various aspects of SPCs. So then we'll get into some Q&A. First, we have Kelsey Bryant, who is an associate professor of medicine, certified hypertension specialist from the ICANN School of Medicine at Mount Sinai. We have Katie Derington, who is an assistant professor of medicine, board certified ambulatory care pharmacist, certified hypertension specialist at the University of Colorado. We have Scott Flynn, who is a regional medical director at Promise Health Plan as part of Blue Shield of California. And then we have Nicole Therrien, who's a pharmacist and my colleague at the Division for Heart Disease and Stroke Prevention at CDC. So, as I just want to sort of repeat, as Jenny said, please put your questions into the Q&A section of Zoom. It might be under your More button, depending on how you have things set up. We really want to make sure we get your questions answered, including any myths that you've heard. So, Anne, can you advance? Oh, there we go. Never mind. Sorry about that. Throughout our conversation today, we'll also have a series of poll questions to gauge your knowledge, attitudes, and behaviors related to SPCs. And we would appreciate your participation in those polls, including this first one. So, Anne, could you please launch the poll? So it says the following best describes my practice regarding single pill combination antihypertensives. I use SPCs regularly as initial therapy, and to consolidate regimens, I use SPCs but never as initial therapy. I rarely use SPCs because I think they're hard to titrate. I rarely use SPCs because I worry about costs. I rarely use SPCs because I'm unfamiliar with available combinations and I have never prescribed an SPC. So we're going to give it a few minutes while people complete this, but I do also want to let you know that in the coming months, the Journal of Human Hypertension is publishing a special issue specifically on antihypertensive combination therapy, for which Kelsey and Katie are two of the guest editors. And so I think Katie put a URL in the chat where you can see the call for journal articles and find out more information. So I think that's going to be really exciting. And maybe we can just, for the sake of time, go ahead and end the poll. And let's see. Is everybody seeing the results? So we've got,
Yes.
yep, okay. So we've got people who use SPCs regularly as initial therapy, and we've got folks who use SPCs but never as initial therapy, sometimes as a second step or when consolidating regimens. Okay, I think we've got information for both of those groups of folks, and anyone else if you did fall in one of those other categories but didn't get a chance to answer the poll. So with that, I am going to turn it over to our first panelist, Katie Derington, to talk through some efficacy and safety considerations. Katie?
Hey, thanks for having me. I'm really excited to be here with you all. I'll give a little bit of an intro to single pill combinations because we do have some folks who have never prescribed them before. And hopefully those who have and like to use them regularly also learn a little bit about the history of antihypertensive single pill combinations. Or Hilary, as you mentioned, we're also calling them FDCs, fixed dose combinations. Some of us may say polypill. Traditionally, we think of a polypill as one pill that has different medications to treat different conditions. Whereas what we're talking about here for antihypertensive SPCs is one pill with multiple medicines to treat one condition, blood pressure. And I was looking at some FDA files, and I could see as far back as 1950s that there was a single pill combination called Diupress, a combination of chlorothiazide and reserpine that was FDA approved to control blood pressure. So SPCs are not a new concept by any means. And if you look at this little screenshot here that I took of PubMed, nearly back to when PubMed started indexing, there was publications coming out about blood pressure treatment with SPCs. And those blood pressure and that research started to really ramp up after 2005. There's a lot of reasons for that, part of which is we have such an amazing menu of different antihypertensive single pill combination products that we can give our patients. I mean, I'm not sure many other drug classes where you could say, hey, here's a menu of 28 different options you can prescribe your patients. It almost gives us a little bit of decision paralysis sometimes, but all of the ones that you see here listed in blue are generically available as well. So we see different types of class combinations. The only two that are brand only at this point are azolsartan chlorthalidone and our most recent product, which is telmisartan, amlodipine, and dapamide, which was approved last fall by the FDA. But even the azolsartan chlorthalidone product had a generic approved by the FDA in 2025. It's just under litigation with some patent lawsuits. But regardless, we have so many medication options. They are all generic. It's important as a pharmacist, I also point out that generic availability is not synonymous with patient affordability. So even if something's generically available, it may not be affordable to the patient. Coverage varies across different payers and formularies, and Nicole and Scott will talk a little bit about that as well. If you have questions related to those things, please put them in the Q&A. But part of why we were wondering about the varying menu of different options we have is, are people using them? And if not, why? Somehow we have all these options and it's still not enough. So in one of these analyses we did looking at the population cohort NHANES 2015 through 2020, if we took all those people who have high blood pressure and see that they're taking multiple medicines to treat that high blood pressure, only 27% are using an FDC or SPC. So a quarter of people are actually using an SPC when they could be using one. And we were thinking about, oh, why is this? What's going on with the actual medications they are using? Well, it turns out that if we look at the actual medicine combinations that people are using, only half of people are using an agent that could be converted if we snapped our fingers to a single pill combination product today. So this is partly a prescribing issue that we need to address as a community, that the medicines that we're giving are not compatible with the current availability of single pill combinations in the United States, at least. And so I want to kind of give a case to you all about why we want to think about single pill combinations as the treatment of choice for most patients with high blood pressure. And this takes us back to some pharmacokinetics, pharmacodynamics about how blood pressure medicines work. And these are some generic comments and statements. It's not perfect for every medicine or every side effect or every effectiveness outcome that you're looking at. But when we think about high blood pressure medicines, typically, as the dose increases, which you see on the x-axis here, and if you look at the blue line, our blood pressure lowering effect is pretty significant in that first, half to quarter response or dose, and then even up to a half a dose, we see a pretty good BP lowering effect that tapers off after a while. So even as the dose increases, we don't get much more effectiveness after a certain point. This is very different from the side effect response. So as dose increases of a drug, the side effect response is nearly linear. So no matter what, if we're increasing the dose, we will get an increased risk of side effects. So we're trying to hit this point somewhere around a low dose, middle standard dose, where we have a greater likelihood of blood pressure lowering and a lower likelihood of side effects. And if you think about repeating this across different medicines in a patient's body, we're looking for that additive synergistic effect to improve blood pressure lowering in a patient. And when they've looked at different combinations and different ways we can titrate patients up in how they're treated for high blood pressure, there was an amazing meta-analysis done and published in Lancet last fall. And they looked at 484 trials, over 100,000 participants with pretty high baseline SBP. Patients in these trials who were started with initial monotherapy only had an SBP reduction of about 8.7. After that point, if you double the dose of that monotherapy, you only get an additional 1.5 SBP reduction. So this stepped care approach, where we take a start low, go slow method, only gets you about a 10 millimeter of mercury reduction in SBP. Whereas if you start initial combination therapy, you get an SBP reduction of about 15. And if you double both those doses thereafter, you get an additional SBP lowering of 2.5. And the authors of this paper did a great job creating a really great website. You can go to this bpmodel.org and try to put in some patient information that and see what kinds of medications and doses might work for you for a specific scenario to get a patient to their goal blood pressure. But ultimately, the evidence is fairly clear at this point across different trials, but also observational cohorts, that when you use combination therapy, whether it's multi-pill or single pill, you increase the likelihood of achieving BP control. Single pill combinations increase adherence by 20%, which I think is a fairly conservative number based on practice. We see increases in adherence probably more than that. Combination therapy, especially at low doses, reduces the likelihood of discontinuation. And that, of course, is a dose-dependent effect for when we think about side effects as well. So we're really trying to optimize this treatment period, especially early on where patients come in. We need to give them a medicine. We want to keep them on something and make sure that we get them on a durable regimen from the beginning. And this is where SPCs come in to prevent that inertia, be effective, and also be safe. Back to you, Hilary.
Great. Thanks, Katie. And gosh, I just learned so much from you in those few minutes. I have to say, the generic availability does not equal patient affordability. That I'm going to put on a post-it up in my office because that is so true, especially for SPC. So I can't wait to hear more about that from Nicole and Scott. With that, I'll turn it over to Nicole to talk a little bit about coverage and economic outcomes.
Thank you, Hilary. Hi, everyone. My name is Nicole Therrien, and I'm a pharmacist with the Division for Heart Disease and Stroke Prevention at the Centers for Disease Control and Prevention. I'm excited to be with you today to briefly talk about two analyses related to SPCs in Medicaid, one coverage analysis and one economic analysis. In this economic analysis, which you can see the link at the bottom of the slide, we compared SPC therapy, which we did refer to as FDC in this paper, and combination therapy using single agent pills, which was referred to as multi-pill therapy, among adults with hypertension with pharmacy claims for an SPC or at least two classes of single agent pills using data from 2017 to 2021 among Medicaid patients. There were several outcomes for this study and all assessed with just a 1 year post-index date for the medications, the index date for the medications. Outcomes included medication adherence, healthcare utilization, hypertension-related and cardiovascular disease-related medical costs, as well as costs for antihypertensive drugs. Today, I'm going to focus just on the economic outcomes. We found that SPC use was low in the study population. Nearly 80% of the study population was not using SPCs. Of the 22% who did use SPCs, 14% had claims for both SPCs and single agent pills. And these individuals were ultimately not included in this MANUS analysis, but they were included in sensitivity analysis with similar findings. For those with non-capitated insurance, SPC therapy was associated with lower hypertension-related medical costs, lower CVD-related medical costs, and lower medication costs. SPC therapy was also associated with higher medication adherence, as Katie mentioned, and fewer hypertension-related emergency department visits and hospitalizations. While the previous study looked at economic analysis with and outcomes with actual use, finding that SPCs may be associated with improved healthcare utilization, and economic outcomes, the study sought to answer a complementary question. What is the status of coverage of SPCs in health plans, specifically Medicaid fee-for-service and managed care plans? In this study, we coded and analyzed coverage of SPCs in those plans as of 2022 using publicly available plan formularies and preferred drug lists. To address coverage status nomenclature differences between plans, we categorized coverage status into 4 different categories. The first, preferred or other higher level of coverage with no formulary restrictions. And formulary restrictions referred to prior authorization requirements or step therapy requirements that could complicate coverage. 2 was preferred with some of those formulary restrictions. 3, non-preferred or other coverage that wasn't considered the highest level of coverage, and 4 for medications that either weren't listed or included on the formulary. We assessed coverage of SPCs at the level of the individual plan as well as by state, including all health plans in that state. And we also assessed coverage for each individual SPC as well as by therapeutic class. The link on this slide will take you to a state-by-state coverage summary that shows the coverage by medication and plan in each state. We found that, as you can imagine, coverage was very complex across Medicaid plans in the states. But briefly, no single SPC was preferred in all plans. However, losartan hydrochlorothiazide and lisinopril hydrochlorothiazide were each preferred by 99% of plans. And valsartan amlodipine was preferred by 72% of plans across the country. We also found that 56% of plans required either prior authorization or step therapy for at least one SPC that was covered in the plan. All plans covered at least two SPCs containing an ACE or an ARB plus a thiazide diuretic. 80% of plans covered at least two FTCs containing an ACE or an ARB plus a calcium channel blocker, and 50% of plans covered at least one SPC containing three agents, of which there are a relatively small number, as Katie shared. Thank you all, and I will pass it back to Hilary.
Great, thanks, Nicole. And I have to tell you the 56% of plans requiring prior authorization or step therapy for at least one of their SPCs. At some point, we need Scott to talk about that. Why is there prior authorization? But I will turn it over to you, Scott. You don't have to address that now.
Happy to address it. Thank you, Hilary. That's why I'm here, right? Hi, everyone. Scott Flynn, Regional Medical Director of Blue Shield of California Promise Health Plan, and thanks for inviting me. As you allude to, a couple of great things that our previous speakers pointed out, both Katie and Nicole. Many of these meds are generic. I think Katie had that slide up there, 28 of them are generic now. And as you stated, not just because it's generic doesn't mean it's covered. And I thought that Nicole had a very good coverage of that also. So not all the generic combinations are going to be covered, but you saw 100% of plans have at least two of them, right? It's not like there's nothing out there. And the lisinopril or losartan hydrochlorothiazide combo is a great combo to start them on. Way back when we started working on the Right Care Initiative here in San Diego, we were talking about starting with single pill combination therapy for a number of reasons. One, as alluded to earlier, is it seems to be more effective than starting at one. And as that great slide that Katie had showing, as you increase the dose in a stepwise therapy, all you do is increase side effects. You don't improve outcomes. So starting off, and also was alluded to, most people need more than one therapy. So why don't you just start with two? If they're going to need it anyhow, and you start off with a modest dose, so you're going to decrease the side effects, you're going to get better compliance, as was pointed out previously also. So it's like, okay, great. So do we need to have all 28 covered for everyone? Is that the goal? Probably not. Do we have plenty of options that are out there available that are generic and covered? I went and looked at our formulary just to make sure we have multiple options that are covered at tier one, which means depending on the plan, a $0 to $10 copay. So $10 copay for a 90-day supply of hypertension medicines, which can save your life. That sounds like a pretty good deal, right? The other thing that we found, and we saw in this poll today, there was roughly a third of folks use these routinely, a third of them use after they've tried monotherapy, and a third have never tried it. That's kind of been our experience too. And the question, of course, is why? All right, the first argument is it costs too much. Well, no, there's 28 generic options, and there's a bunch of them that are indeed covered and covered at tier one. Now, it may be different between different plans, but as alluded to earlier, 100% of plans have some kind of lisinopril hydrochlorothiazide combo that's available, and that's recommended for most folks. Obviously, there's some exceptions. You may want to start with a calcium channel blocker, hydrochlorothiazide combo like amlodipine with something. That's fine also, and we have those covered, and most plans have one of those covered. That wasn't specifically called out in the previous presentation, but I'll bet you if you look, you're going to find it. And as alluded to also on the previous slides, outcomes are better, right? There's decreased ED utilization, there's decreased heart attacks, It's overall, it's cheaper, better, more compliant, better outcomes. So what is the holdup? Well, it used to be insurance. It's not insurance anymore. It's probably something just more realistic about human nature, and that's called inertia, both provider and patient inertia. So I'm the old guy here. When I was in medical school, I was taught stepwise therapy. So you get into practice patterns as you develop your practice and you prescribe, your prescribing patterns become pretty well set. The old joke was when you were first in medicine, you know 10 things about 1,000 medicines. And then when you're an old guy like me, you know 100 things about 10 medicines, and you tend to use those 10 because you get very, very comfortable with them. So it's interesting that the uh, way we practice is the way we practice, and sometimes it's despite the evidence that's out there. It's finally in the guidelines now that if you have stage 2 hypertension, you ought to be thinking about using an SPC to start with, a single pill combination. When I see patients, I still moonlight in urgent care and see patients, and I start them in urgent care on something. If there's no contraindications, I'll go ahead and give that lisinopril 10 hydrochlorothiazide 12.5 combo pill to get them started and send them back to their primary care doctor so they can continue. But I get them started on it right away because one of the things we've seen is this inertia can cost lives. We all know somebody who's had a heart attack at age 50. I don't know if y'all old enough to remember James Gandolfino, who was a very famous actor, and he died at 56 or 55 from a heart attack. He had uncontrolled hypertension. He's 55, all right? That's right in the prime of your life. Um, it's just a tragedy. Someone would die from something like that that is theoretically preventable. Our chair of the right care down here in San Diego, Tony DeMaria, who is the editor-in-chief of the Journal of American College of Cardiology forever, he was very fond of saying, we all got to die of something. Let's not die of something stupid and preventable. And hypertension is one of those things. It's not sexy. It's not the latest CAR T or gene therapy or anything else like that. It's just something that works. It's a silent killer. And this is something that can really help us get folks under control quickly and effectively, economically, less out of pocket, with good outcomes and decreased side effects. So it's kind of like, all right, inertia. Let's go, folks. Let's get on board with these recommendations. It took a while to get here to this. Um, I guess, thank you for putting my slide up here. I forgot to advance it. The reason the picture's there, and I don't know if many of you are musical fans, but this is Tevi from Fiddler on the Roof. And one of the most famous songs that was in there was Tradition, right? Why are we still doing this? Tradition. All right, let's break some tradition, get our folks treated the right way, and get this thing moving. Thanks, Hilary. Back to you.
Great, Scott. Thank you. And I think we're going to be coming back to that idea of tradition and how to break from tradition. So thank you. Next, we're going to pass it along to Kelsey Bryant, who's going to walk us through some case examples. Kelsey?
All right. Thank you all so much. I'm really excited to present alongside this group today because I think it really shows the multidisciplinary approach that's required to really understand these topics. And then my perspective is really coming from the person on the ground who's doing this. So I'm prescribing these medications, I'm managing the side effects, I'm switching agents. And so I hope that we can have an interesting discussion and hopefully share some pearls around this. So first, we have a 47-year-old female patient who's presenting to established primary care. Her kids are getting older and she finally feels like she has time to take care of herself. I don't know if anyone feels that way. She feels well and she's here to just get checked out. Her initial blood pressure is 150/92. She rests for a few minutes. On repeat, it's still high, 147/89. She notes that her partner has high blood pressure, and she's used their machine recently just to see and thinks the top number was in the 140s. On further history, you learn that she had preeclampsia in her second and final pregnancy, but her blood pressure normalized after, and she was too busy with young kids to follow up. So she's really not sure how long it's been high. She doesn't smoke, she doesn't drink alcohol, and she's not taking any medication that could raise her blood pressure. And if you could launch the poll, what is the next best step? So this is not meant to be a hard question. This is meant to talk about some discussion. But are we going to recommend lifestyle changes, start a thiazide diuretic, start a beta blocker, or are we going to start a combination calcium channel blocker, ARB? All right, I'm going to give another 10 seconds. All right. So I'm not sure if you all can see the results, but I can. So I'll just briefly review. About half of people said calcium channel blocker ARB. No one said beta blocker. It was a good distractor. A few folks said thiazide, and then a few folks said lifestyle changes and follow up in 3 months. So the correct answer in this case is start a combination calcium channel blocker and ARB. And you could really insert any SPC here, perhaps personalized based on other comorbidities that the patient has, which this one doesn't. The reason that the others are incorrect, so first, of course, lifestyle is the backbone of any hypertension therapy. However, this patient has stage 2 hypertension. And there were a couple of clues in the question stem to allude to that. So she was elevated on repeat. She's checked at home. It's still high. And then she also had other risk factors going back to her pregnancy. That preeclampsia increases your risk in the future. The thiazide diuretic is a perfectly appropriate first-line agent, but the trick here with this question was that it wasn't in combination. And then beta blockers have fallen out of favor. So here we are starting our combination medication, and perhaps there are some questions around it. So the second part of this case, you think to yourself, all right, I'm going to do it. I'm going to start this patient on combination therapy. So you assess the patient, you think about a recent talk that you heard about updated hypertension guidelines, and you recommending combination pills. You're a little nervous to use 2 drugs at once. You're not sure how much the blood pressure is going to drop. You're a little nervous about teasing out side effects. You're worried that you just won't tolerate it very well, and maybe it's going to be too expensive. And so I know that as a busy primary care doctor who wears many hats, that if I prescribe a medication and I'm not sure it's going to be covered, it's a real pain down the line to get the call from the patient and then try to figure out what they need authorized, et cetera, et cetera. So all these things are very real. But in our case, we know a clinical pharmacist who can help us answer some of these questions. So I want to pass it to Hilary to guide us through a little bit of a discussion, and then we can pull out some of the nuance from this case.
Great. Thanks, Kelsey. So I have several questions for all of our panelists. Katie, maybe I'll start with you. And I think you touched upon this earlier, but how much blood pressure lowering can we expect from a single agent versus like 2 combined?
Yeah, absolutely. So for this patient, she's never been on therapy. Based on the most recent data that we have, if we start one medicine at low to standard dose even, we can maybe see her SPP drop about 8.5 to 9 millimeters of mercury, which would get her below 140. But our most recent guidelines would ask us to push that even further down to less than 130. So we need more blood pressure lowering for her. And I put this in the chat. It's really, really easy to forget this, but in 2017, our guidelines changed our definition of stage 2 hypertension. Our definition of stage 2 is now any SBP over 140. And so we're no longer looking for those folks who need an SBP reduction more than 20. We're looking for anyone who has stage 2 hypertension, and we want to bring it down to less than 130. She's a candidate for the single pill combination. The only other nuance I want to bring up here, Kelsey, and it goes back to like what combinations are available. There are some gaps in the menu that we have. So if this patient were younger and wanting to conceive again, and they did not want to be on an ACE inhibitor or an ARB, we're missing an SPC that has only a calcium channel blocker and a thiazide diuretic. And so for that kind of patient, maybe this is someone who you would start on multi-pill therapy, a low dose thiazide diuretic, and then a low dose amlodipine or something like that. So another nuance to just change it up a little bit.
Yeah, that is a great point. And I was just going to ask Kelsey, how would you approach agent selection in this case and beyond? And is there a subset of patients for whom
Yeah,
you wouldn't use an SPC?
for sure. Yeah. So I think in this case, so Katie, you brought up an important point. I I should have been clear in the questions saying that this patient did not want to have more children. But that is, I think, a really important thing that sometimes isn't always brought up about what people's reproductive plans are. And in some cases, we can cause harm perhaps by starting an ACE or an ARB in someone with a capacity for pregnancy. But we can also miss an opportunity for excellent control in somebody who's not trying to pursue pregnancy. So I think just having those conversations are really important. And my personal practice is to make sure that patients are educated on the risk and know what their risk for pregnancy is before I make a choice to then try to make the most effective choice. Because unfortunately, we do lose some options around those childbearing years. So then the next step is really if the patient has other comorbidities. So thinking about CKD, diabetes with proteinuria, things like that. Occasionally, there are a few agents that might be helpful with migraine prophylaxis, though that's a little tougher to tease out. If there's any way that I can get to kill two birds with one stone, I'm going to do it. And then my next thought is I'm pretty well informed about the formularies in my local area, and there's just like not that many that I can choose from. So there's 28 in total, but there's not that many that I can go to that I know that are covered. And so my next step is to think about how far do I think that this person is from their goal? And if somebody is walking in the 160s, and I believe that blood pressure to be real, maybe I've had the opportunity to verify it out of office, they've got a whole lot to go. That's 30 millimeters of mercury at least to even touch the top of the goal. I'm probably not even going to get there with two agents. And so then I might be thinking about what drugs come in combination with three, and then perhaps start with two. So then I can add a third there. And so it really goes back to that puzzle that Katie put up. And it's less complicated than you might think because you really just need to know what's available to you, and then you'll have your arsenal to choose from.
Great. And so, you talked about formularies and whether or not coverage is available. Scott and Nicole, do you think cost is a concern here?
In general, it should not be. There are many formularies that have that amlodipine hydrochlorothiazide as a typical calcium channel blocker, low dose 5 of amlodipine, 12 and a half of hydrochlorothiazide available. So that should not be a barrier. I think what Kelsey was talking about was very accurate too. Why is hypertension going to be treated any differently than you would um, rheumatoid arthritis or psoriasis or something like that? You know what's on formulary for those kind of conditions. Why not for hypertension? Especially why not for hypertension, something that is so common. You're seeing this every day, three, four patients a day with hypertension at least. If you're in practice, it's a very common thing. So you'd think you'd have that research done and know, okay, I know these are my four drugs I can pretty much go with everybody that are going to be safe to use as a combo, and have that lisinopril hydrochlorothiazide as your one, and then the calcium channel blocker hydrochlorothiazide, and then see if there's others. Also, agree with what Kelsey said is you're probably not going to start somebody right off the bat on triple therapy, but starting off on double therapy right away probably makes sense, and then you can add on from there.
I
Great.
can take the question in the chat about the cost of the three drug combination, and then I am interested to hear what some of the pharmacists have to think about. But from the prescriber perspective, if I am trying to help get drugs in the hand of patients, there are a few direct to consumer pharmacies. So cost plus drugs is one option. I was recently pricing these, and the triple combination pill with amlodipine, olmesartan, and hydrochlorothiazide you can get for around, I think it was around $50 for a 90-day supply, which still might be cost prohibitive for some, but for three drugs altogether, not so bad. Interestingly, the last time I looked at that, the valsartan containing combination was much more expensive. It was like $300. And maybe our pharmacists can speak to why drugs costs have such different costs. I don't really know. Um,
Well, lisinopril, if I may just kick in real quick, lisinopril has been generic for a long time, and it's the old ACE, right? And whereas lysartan is the ARB, more recent, and there may be some more protection around that one. Don't know.
Nicole, do you want to go?
I don't think I really have a lot to add. There are certainly resources to be able to see what coverage you have, whether that be like online resources or if you do have great like in-office resources like pharmacists that may be able to help you locate that information.
Scott made an important comment that when he was talking earlier, and something that you said was inertia can cost lives. And I think that that's really true. And starting combination therapy off the bat is really one way that we can prevent that. And I'm often reassured by how much drop I expect to see. And very rarely do I overshoot. And I overshoot when when somebody actually really has true white coat effect that we haven't been able to verify. But most of the time, with understanding of your formulary and starting two drugs at once, you can get there. And sometimes you can get there in one step. And that is so much better from the patient perspective and clinical workflow perspective, as opposed to, for example, having someone in, starting them on an ACE or an ARB, bringing them back a couple weeks later, checking a BMP, they're not quite at goal, tweaking it, maybe adding a diuretic and then needing more labs in this cycle. Inevitably, you or the patient is going to lose interest and focus on their back pain or their knee pain or whatever. And the blood pressure is still uncontrolled. And it doesn't have to be that hard.
All right.
Yeah,
I'm just gonna,
if I just may, just to reemphasize that inertia again, and I don't think it's intentional. It's just it is what it is. But doctor, I'm going to do diet and exercise. I want to come back in a couple weeks and let's see how we're doing. Well, they end up coming back in 3 months or 6 months, and then you start them on a single pill at a low dose, and then they come back. They're supposed to come back in a couple weeks. They come back in a couple months because your schedule's full, right? And then you do it and you up it again, and you're doing that step therapy. You're going to burn a year before you know it, and they're still not under control. Give them the single combo pill to start with. That gives them a much better chance of getting control, and you get it near time. And check it again in 2 weeks. You don't need to wait for 2 months to see if the blood pressure medicine is working. Literally, 2 to 3 weeks is all you need to see if it's working and it's doing what it's supposed to be doing.
so that's great. There's one myth that I hear a lot that I want to make sure we're addressing. And Kelsey, maybe I'll punt this to you first, but anybody chime in. Let's talk about side effects. How do you assess and manage side effects with combo pills?
Yeah, so I think that it's important to zoom out and remember that hypertension is not the only condition in which we use combination therapy. No one is worrying about the side effect differential when we're taking care of patients with HIV, right? It's the standard of care to use a combination pill, and it's an important backbone of therapy. And we've seen the outcomes in HIV change drastically over the last few decades with this change. But the drugs are still different and they still have different complications. We use combination therapy in asthma, we use it in obesity, we use it in heart failure, and somehow hypertension, everyone's like, oh no, side effects.
Can't do it.
And so my answer to that question, yeah, Hep C, multivitamins, thanks. Thank you, Katie. My answer to that question is you usually know. So most of the side effects are well described. So for example, lower extremity edema and calcium channel blockers, coughs and ACE inhibitors, hyperkalemia and ACE and ARBs, hypercalcemia with a thiazide diuretic, of course, the urinary frequency when we're using a diuretic, all of these different things. Typically, you can tell. That doesn't mean there's not going to be some weird side effect that the patient attributes to the drug that maybe you can't possibly think is the drug, but they're going to believe it. And that's definitely a different consideration. But the other thing to think in mind, just to keep in mind, is that when we use combination therapy, we can often use lower doses than we might have otherwise. And as Katie showed, side effects tend to be dose dependent. And additionally, many of the agents are paired as such that the side effects offset one another. So for example, ACE ARBs and diuretics, the potassium up and down sort of balances out. My personal favorite is the calcium channel blocker and ARB combination. And so calcium channel blockers alone, particularly in high dose, often cause lower extremity edema, which is a benign side effect, but patients hate it. Like they're mad that you put them on amlodipine 10, they come back and they're like, my leg looks like this, it hurts, I don't like it, make it stop. I'm never taking a calcium channel blocker again. But if instead you put them on a combination with an ARB that has more balanced vasodilation, the chances that you actually have that side effect are much lower. And I've now given a patient one medication in moderate dose and balanced out their lab findings, and they feel fine. And I tell them ahead of time and I counsel patients on that. And that's really my approach.
Yep, that's great. So one last question before we move on to our next case, and Katie, maybe you can give me a quick answer. How would you guide physicians who are concerned that SPCs are hard to titrate?
Yeah, first is actual validation because you're combining multiple medicines and there's a bunch of doses for each of these products. So I'm validating in that, like, how do you know which to increase and like, is there an option available for that? But in general, all of these SPCs come in a low dose with all the products that are inside of them and a high dose for all the products inside of them, and then middle versions of each of the medicines inside. So there is a product available to fit the need of your patient most generally. There are, as Kelsey said, some weird side effects that you experience. Maybe there's a regimen that you want, but you don't have an SPC for. So those situations, though, I would argue are quite rare, and that the available menu that we have should be able to get you what you need for most titration ability. One thing I do like to do, at least in my practice, is if I'm asking patients to bring their pill bottles to their appointments so that I can see what they're using, what they have at home. But if I'm changing it, I also give them the opportunity to give it to me to dispose of. So we have an in-clinic disposal opportunity. And so I know I'm taking away their med that they can't, use this specific dose anymore. It's going to be in the pharmacy downstairs in about an hour ready or so. So really trying to ease that transition for people so they don't get confused at home about which pill do I take and when do I change over and stuff. Sorry, that wasn't as fast as you wanted.
No. But that sounds so easy, but such a great strategy, a nice de-implementation of a medication. Thank you. Kelsey, back to you.
I'll read this case, but I just want to address this question here in the chat really quick, where someone says, does one approach the patient with mistrust of the healthcare system medication differently? My answer to that question is that it depends, right? So I try to assess where the mistrust is coming from and why there might be some hesitance. And so, for example, so one way that I might explain how the combination therapies work is to say, most patients are going to require more than one medication to control their blood pressure. And we might be able to do this with lower doses and then have fewer side effects and really explain the details. That said, if a patient's really resistant, I'm never going to force this on them and say, I think this is better and therefore you should do it. And there may be others that practice differently, but my style of practice is very much to give patients a menu of options of what might be reasonable and tell them what my opinion is. But if a stepwise approach was more appropriate for someone to gain their trust, then of course I would do that. So with that, I'm going to switch over and read this case. So you're seeing a 65-year-old man with hypertension for the first time. He recently moved states to be closer to his daughter and grandkids. So this is the first time in your health system. His blood pressure is 142/94. His medications include losartan 50 milligrams, nifedipine 60 milligrams, and hydrochlorothiazide 25 milligrams. He says he takes his medication, but he admits his cross-country move has been a bit hectic and he might have missed some doses recently. His renal function and potassium are normal. So here, what is your next best step? If you could please launch the poll, Anne. All right. It seems like a few people are saying increase to losartan, and most people are saying consolidate to a triple combination pill. All right. And Katie, thank you for your comment here in the chat. I say this often, the best regimen is the one the patient will take. So if stepwise is the right for that patient, then that's definitely the right thing to do. So in this case, you all are picking up on a pattern. The answer here is to consolidate the regimen to a triple combination pill. So there are technically 3 triple combination pills now, but one is brand name only. So the 2 that are widely available relatively are amlodipine olmesartan hydrochlorothiazide and amlodipine valsartan hydrochlorothiazide. The third one, Widaplic, which is the amlodipine telmisartan and dapamide, is in much, much lower doses and is the only triple combination pill that might be sufficient for initial therapy. But that's a little bit beyond what we're talking about today. So our second part of the case, so you asked the patient if it would be easier for him if he had only one pill to take. He tells you he would love that, but he's had high blood pressure for many years and has never been able to only take one pill. And he's frequently told his blood pressure is high. You share with him that there are actually 2 options for pills with 3 drugs each, and the ingredients are quite similar to what he's already taking. He's excited about the idea of simplifying his regimen and feels more empowered to get his blood pressure under control. So I'm going to pass it back to Hilary to guide us through some discussions and nuance of the case here.
Great. Thanks, Kelsey. So I'm gonna punt to Scott for a second. The point that Nicole said about plans requiring prior authorization is still sticking with me. So can you just talk a little bit about from the payer perspective, what are your considerations in creating your formulary? Why would so many plans have prior authorizations for some of these combinations, especially if they're generic?
Yeah, and that's part of the question. Are they generic? Triple pill combinations are, what's the right word? They're not very common. They're not as usual as two pill combinations. Two pill combinations have been around for a long, long time. To have the triple pill combination be covered at a tier one generic would be that we've actually been able to get the price at that generic. Just to reiterate, I think someone said this earlier, just because it's generic doesn't mean it's cheap, right? And that's true also biosimilars. For biologic agents, you may have biosimilars available, but if they're giving a 5% discount to the branded agent, is that really going to be cheap? Same thing here. So it really depends on what the price are and what we're able to negotiate to be able to get those costs down and be able to pass those cost savings on to the consumer.
And Nicole, thinking about the coverage analysis that you worked on, it's got to be because this would be so confusing for clinicians. Within a state, all the Medicaid programs must cover the same medications, right? Is that what you found, or is there actual variation within a state, not just from state to state?
Yeah, broadly, no, coverage was not standardized within states. 24 states did use standardized coverage using a few different like health plan benefit designs, like carve in or carve out for pharmacy benefit, a single pharmacy benefit manager, or statewide universal formularies. Or half of those 24, so 12 states, didn't deliver their Medicaid program through managed care organizations. So by design, they do have a standardized coverage within the states. Another 8 states had somewhat standardized coverage, but it was sort of partially standardized. So ultimately, over half of the states did not have standardized coverage. So they would have from a little bit of variation to pretty large variation of coverage for these medications across plans. And certainly there are states that have just a few plans in Medicaid and some states that have a very large number. So depending on the state, it could be very simple to understand Medicaid coverage or very complex.
And that's no different than the commercial world,
Yeah,
where there are no state formularies at all, and it's the
right.
Wild Wild West completely. Um, the advantage we have here in California, or disadvantage, whichever way you want to look at it, is the state runs the pharmacy benefit. So it is one controlled, same um, formulary for the Medicaid slash Medi-Cal, like we call it Medi-Cal here in California, patients. The commercial world's a whole different animal.
Yeah.
It's
So we
everything
only have a
different.
few minutes left, so I'm going to ask a couple more questions, and then I have my final question for everyone. Kelsey, how, so in the case study, the gentleman had, a couple single pill, free equivalent medications he was on. How do you approach dosing with switching from those free equivalents to combo therapy, especially if the agents aren't the same?
Yeah, so it takes a little bit of nuance and understanding of what you have available to you. And if we're thinking about a triple combination, for example, it's not that hard because there's only 2 options to choose from. So either you have access or you don't. Nifedipine specifically, I put that in there because it doesn't come in any combination. And so if we're going to put someone on a combination pill, we have to switch them to amlodipine. Really, with most antihypertensives, I think about them in low, medium, and high. And you might not have every dose memorized, but there's going to be a low, medium, and high. For the most part, some of them only have 2 options for all of these drugs. And so if you know they're starting from, I think this guy was on losartan 50 or something. That's the medium losartan, right? So we're at the medium dose. So if I felt like the adherence was okay-ish, then I would probably do an equivalent dose and put them on the medium olmesartan or valsartan combo. if I felt like there was no way that they were taking the medication and maybe that we were actually over prescribing because someone just kept adding pills because their blood pressure was still high, I would actually probably be a little bit more delicate and maybe even just start a double in a lower dose if I was worried that adherence was the bigger issue. So the summary is really just like low, medium, and high. And if you have to look up what low, medium, and high is, the exact equivalency isn't that important.
Okay. And Katie, any pharmacist thoughts on cross titration? And do we need to worry about washout periods?
That's a great question. And the guidelines actually don't even really touch this, so thanks for bringing it up. In general, there's a few principles that we need to abide by. The first is that we do not want a patient exposed to an ACE and an ARB at the same time. And so it is recommended to wash out one before you start the other, rather than doing like decreasing one dose while you're starting another and doing that cross titration. So we can do that over a period of a week or so, depending on the patient. The other rule that I think is helpful is if a patient's on a beta blocker or clonidine, especially if they've been on it for a long time, they will need a slow taper to prevent rebound hypertension, chest pain, things like that, tachycardia. So those are the typical rules. Depending on the dose that the patient was taking, you may be able to just kind of stop it and switch over, right? Like if they were on a super low dose of HCTZ, I can stop you today and start something new tomorrow. But depending on how big the dose is, I usually opt for like a 1 week wash out, maybe having the dose in a few days or in a week or so, and then starting the new pill the next week. But as the best regimen is the one that the patient will take. So this should be a shared decision-making conversation. I can do it this way. I can do it this way. What would work best for you?
Sure. Great. Thank you.
Yeah.
So my last question for everyone, and there was a great question in the chat that really related to this, so I'm gonna read that. If we're looking at low amounts of prescribing, should PCPs need at least 1 hour of CME mandated? My question was, how do we change this paradigm? We keep hearing low and slow versus starting on single pill combos. Like, what do we do? Where do you start in the training chain? Like, how do we change that paradigm? The $1 million question.
I am trying to change the paradigm with slowly making my way through various residency and academic programs and teaching on the topic. And one thing I always say is that this is not a one size fits all thing. Of course, not every patient is appropriate for an SPC. And of course, there are some people that you should go low and slow and cautiously on. We have frail older patients. We have people with advanced CKD. We have all of these different competing factors. And that is the beauty of medicine. And that's why you are their provider and you get to know these people and make decisions based on their nuance. But for the vast majority of people that are not that complicated, that do not have side effects and badness yet, we can just get it done with one pill and then forget about it. You don't have to worry about it anymore.
We have time for one more answer.
Yeah, I'll go real quick. What we did in California, two things. One is there's something called the Right Care Initiative, which helps promote these kind of principles. We adopted an algorithm for hypertension control. It started with a combo pill 10 years ago, and we've been promoting that here. The other thing that happened is, you always say follow the money. One of the things that covered California and CalPERS both did was on their quality rating systems for the bonuses for docs or for health plans, they put hypertension as one of four primary quality objectives that you could either make or end up actually losing significant amounts of money on. Hypertension was one, diabetes, colorectal cancer screening, and CIS-10, the Children's Immunization 10. So the states actually emphasized it. So how do you emphasize it? Put it on the metric. What's the best way to get folks under hypertension control? Start with a combo pill.
Great. Thanks, Scott. So we've got one last poll we really want everyone to chime in about. And if you could launch that, please. Based on what you've learned in this webinar, will you change your prescribing behavior toward the use of SPC therapy? Please respond. And while you're responding, I just want to let you know that in December of last year, the American Heart Association published a scientific statement on single pill combination therapy for the management of hypertension. We just put that link in the chat. Please check it out. It's just additional information. And there's a great figure on there on the impact on SBP reduction and cardiovascular disease risk reduction between single pill combos and stepped care. With that, I want to say thank you so much to my wonderful panelists who were amazing. Thank you for sharing your knowledge and expertise with us. Thank you to our participants. We really appreciate you hanging in there. Jenny, back to you.
So just quickly, if you have any follow-up questions, I'm sure our panelists would be happy to follow up with you offline. We will be sending this recording out as soon as it's available through Zoom. Please feel free to share it with your colleagues, and thank you all so much. I hope you have a wonderful afternoon, a great rest of your week. Thank you, everyone.